Meu nome é Paulo Guilherme, eu sou médico patologista em Belo Horizonte e estou aqui junto com o Dr. Thomas Clancy, cirurgião do Dana-Farber Institute e da Escola de Medicina de Harvard em Boston, Massachusetts, e participando aqui do 7º Simpósio Internacional Oncoclínicas no módulo de câncer da junção gastroesofágica e de câncer gástrico. O Dr. Thomas é cirurgião e vai falar um pouco sobre 2 pontos que são extremamente importantes, que é a questão da dissecção linfonodal nesse tipo de neoplasia durante os procedimentos cirúrgicos e a questão da importância do cuidado que o cirurgião deve ter em relação às margens cirúrgicas. So, Dr. Thomas Clancy, very nice to talk to you.
Very nice to be here. It's really our honor to be here from Dana-Farber in Boston.
Thank you so much for being here. So, I was telling for the people that are watching us that we're going to discuss a little bit, and we'd like to know about your experience and to know the importance of lymph node dissection in the surgeries of gastric cancer and GAG cancers.
Well, this is really a topic I think that has evolved over the last 2 decades, and as we know, extensive lymph node dissection is performed in Eastern countries, but has previously not really been shown to be quite as beneficial for treatment in most of the West. So we've known now, though, that recently data has shown that long-term follow-up of the Dutch gastric cancer trial shows improved disease-specific survival in patients who undergo extensive lymph node dissection. Mm-hmm. Exactly which lymph nodes to take is a matter of some controversy. So typically surgeons in a high-volume center in the U.S. will not just take the perigastric lymph nodes, but nodes along the celiac, porta hepatis, and splenic arteries without doing the retroperitoneal nodes.
Okay, and how do you think that's important for the surgeon to really have an expertise to perform this dissection?
I think so. I think that especially with minimally invasive procedures, more and more of our procedures now are performed in laparoscopic and robotic means. And performing these operations with adequate lymph node sampling really does require just a little bit more level of expertise.
Okay. Another point that is very important, and we have the opportunity to see you talk about that in your presentation, was the point about the surgical margins, which means to be a very important point to be considered in GEG surgeries. What can you tell us about that?
Well, one fear I have as a surgeon is if we have a tumor of the proximal stomach where we plan a gastrectomy and then find that in the operating room the proximal margin is positive.
Okay.
And then it's very challenging to do an esophagojejunostomy up into the chest. We can sometimes do a left thoracotomy, but there's a limit to how much room we have. So it requires precise preoperative planning. And the way we approach this is we know for any tumor of the GE junction, right at the gastric cardia, you really need to be prepared, I think, to perform an esophageal gastrectomy ahead of time. Mm-hmm. So we'll use precise preoperative planning with EGD, endoscopic ultrasound, and we'll more and more now use a team approach with one surgical oncologist planning the abdominal portion for lymphadenectomy, creation of the pouch, and adequate margins on the stomach, and the thoracic team for lymphadenectomy and distal esophageal resection with anastomosis in the chest.
Okay, and you told in your presentations, you told us specifically about the importance of the ultrasound. Is it really fundamental to perform a good surgery?
Yes, in our practice, I do feel that that's now probably the most important preoperative staging modality. Because even when the mucosa appears to be normal, particularly after chemotherapy or radiation, we can often find submucosal extension of tumor proximally. So in an area we feel the esophagus might be normal, we then find that intraoperatively there's tumor there, and that can have devastating consequences.
Yeah, definitely. Last question, since I'm a pathologist, is it useful to perform frozen sections?
Frozen section is quite challenging. Okay, and we know in the best of hands, the best scenario, best pathology, there can be probably 10 to 15% of false negatives.
Okay.
And at the same time, we may be forced to do this. For instance, in a tumor where we need to perform a gastrectomy, I will perform a frozen section of the proximal margin just to see if there's any more that we need to take. I do think that this is an important part of our operation to avoid negative margins, although we know that it is not perfect.
Okay. Thank you very much,
You're
Dr. Clancy.
Okay.